Thank you. Privileged to be able to chair this first session. And our first speaker is Margret Gudnadottir. Did you get that right? Thank you. I don't speak Icelandic, I'm sorry. Who's a clinical academic. In my world, it's called a clinical academic, which, yeah, this is on, which means that she combines, it's the toughest gig, I think, in our worlds. She combines being a team leader and a clinical specialist with also completing a PhD. So that's basically 2 jobs, 3 jobs, maybe, yeah. And what she's going to talk to us is about home care. And I think that's really good that you're doing this, because Crystal reminded us yesterday, much of our narrative around fundamentals of care is about people in hospital, but it equally matters wherever people are. So I'm really looking forward to hearing your keynote.
Well, good morning. Can you hear me in the back? Okay, good. So nice to be here with you. What an inspirational conference this really is. Has made a lot, has made my day yesterday and probably today also. I would like to thank the ILC for giving me this opportunity. You want my slides on? Maybe? Okay. Yeah. Okay. I think we have the right one. It was in other color when I was at my hotel, but this will do fine. Green is my color, so that's fine. Yeah. So thank you, ILC, for giving me this opportunity to share with you a story of a project that I've been so fortunate to lead for the last 1.5 years. The reinforcement of home care for frail elderlies in Reykjavik, the city of Iceland. Yeah, this is the one I wanted to show you. So here you see our old flag. So during this presentation, I would like to talk to you about home care in general, both its importance and its beauty. I will tell you a little bit about the situation in my home country and how COVID-19 became the push we needed to act on a long-known need for change in how to support families living at home with frailty. And this will lead us to Selma, the new project that allowed us to take vital steps to forward a designated interdisciplinary and intersystemic collaboration, and to do our share in the role of breaking down silos in the healthcare system, and thus making it possible to do better in the care and treatment outside of the hospital setting, along with the vital aspect of empowering home care nurses in their approach of fundamental care. Just to clarify a little bit my passion for home care, I would like to tell you a little bit more about my background. Today, I am licensed as a clinical nurse specialist in home care, and in my master's program of interdisciplinary home care, I focused on the collaboration of the social home services and the home care nursing services, how we are meeting the holistic social and healthcare needs of elderlies living at home. That research led me to a wider approach on how we can do better in integration of services between the systems of home care, primary care, and hospital care for these frailest group of people in our society. And that is my full-time job at the moment. But alongside that project, I'm also doing a PhD study where I'm narrowing down, especially to the care and support provided to families living at home with dementia. But that's another story. As you heard, we do have many hats here. So This all started when I was a young nurse. I was brought up in the exciting atmosphere of the emergency department. But I decided to apply for a 3-month temporary position as a team leader in home care. And to make a long story short, I was fascinated by the environment of home care nursing, and I knew this was the platform I wanted to focus on in my career. So I never quit. And here I am 12 years later, because I instantly saw the endless opportunities and the importance of building up a stronger service at home, and I wanted to be part of that development. The main difference I saw between home care and hospital care was the increased will and power of the individual in his or her own environment. I was used to the roles in the emergency department, where the hospital staff is in charge and the patients sit and stand as they are told to, with very limited control of their own situation. But as a home care nurse, I come as a visitor to my patient's home. I do have my professional knowledge and skills, but I must respect and work from the patient's will of collaboration. And that is the art and beauty of home care. Meeting the individual on his or her premises at his or her territory, but often in very complex healthcare needs. The home environment is a precious place to provide a person-centered care. It increases our understanding of all the factors influencing person's health status, like the condition at home to operate, the individual's self-efficacy, and his communication with or support from his or her family. We, as healthcare professionals, are all aware of the major role of family caregivers in keeping things together at home and the care burden that often affects their own health. The environment of home care provides a special opportunity to read into these circumstances and reach out to the family with a closer connection and possibilities of more proactive action in support. The aging of population is a fact, and we hear about the silver tsunami all over. But Iceland is a small and young nation with less than 400,000 inhabitants. And still today, only 13% of the population is over the age of 67. So it's quite young, but it is fast growing the next decades. And in a very short time, we have seen enormous changes, but we are still population-wise around 20 years behind the aging evolution of other Western countries. So that could mean we could have been able to learn a bit from you and others. But despite that, the healthcare system in Iceland is in the same deep trouble as other nations. Here in this picture on the left, you can see how much has changed in only a few decades. You see here an Icelandic family in the 1920s, when generations were living together with a heap of children, living in a typical Icelandic turf house, which was the habitat of the majority of the Icelandic population well into the 20th century. And in fact, my mother-in-law was born in one of those houses, cold, dark, and humid. Today, we treasure these houses and think they are beautiful and precious, but my mother-in-law, she does not miss her childhood home. In the early ages, families and generations lived together and took care of each other. Today, we seldomly live with old parents or grandparents, but most families do want to stand by their loved ones. They want to be part of their care and support them in living an independent life at home, despite their frailty. And to be said, the healthcare system depends on families' contribution to care. Elderlies do want to continue to live at home as long as possible, but only if they feel secure and get the support they need. In an Icelandic research on home support for elderlies in need of care, 81% received assistance from relatives, neighbors, or friends, but only half of them got a formal service assistance to their home. And life can easily hit a turbulence to despair when families become aware of how alone they stand in their care for their frail loved ones, and when they feel the lack of resources and support at each service level. And this makes me wonder about the responsibility of the formal care system regarding the often overwhelming care burden of spouses and close family members. Where is our responsibility to that? In line with how described earlier, what kind of importance and advantage the home care setting has regarding working with and connecting to the family in its own environment, it is sad to see how task and time pressure driven the home care service is and how isolated the staff is, just as we heard yesterday. At least in Reykjavik, and as I have heard in many other places, home care is very much task-oriented, focusing on short visits in and out of patients' home, helping with medication, wound treatment, and basic assistance with daily living. And home care nursing has a very limited connection or collaboration with the primary care and the hospital care. And therefore, it is not a strong part of the service chain of healthcare for frail elderlies as it should be. There has been no option for a proactive doctoral visits at home, resulting in the home care staff standing alone, persevering until there is an acute situation, and their patient has no other option than to be moved to the emergency department because he or she was too frail to go out of their home and seek doctoral service at the healthcare clinic or at an outpatient ward. And believe me, the last thing the home care nurse wishes for its patient, for its frail patient, is to be sent into this hectic environment of the emergency department. We that have been working in home care for years have been pointing out repeatedly the need of doing better for the frailest ones living at home. But sometimes something good comes out of a bad situation. After a dramatic outburst of COVID-19 in our geriatric hospital wards in 2020, the focus of the government shifted towards increased care and treatment at home to keep the elderlies away from the hospital and thus minimizing the burden and overload of the emergency care. So that was the drive they had. But this gave us the opportunity to fulfill a long-sought goal. All of a sudden, we had both the money and the government's will to set up a specialized team of clinical nurses and physicians that could change the culture of healthcare at home and offer a holistic and tailored approach to each family's needs. With home assessment, treatment, and follow-up, giving time and space for an active listening and proactive reaction, making it possible to turn threatening health issues into better way and increase the well-being of families living at home with severe frailty. Our team is called Selma. The name Selma has some kind of a gentle sound and effect, but it's so nice to know of Selma in the supporting environment. So it's good to know about her, but her name, Selma, is also an abbreviation made from Icelandic keywords that we want the service to stand for. An integrated service that offers assessment, treatment, and follow-up at home. And you know what? From these keywords, we could even make a very special English version. The team could be called Faith. Okay, this is Selma. Our team of 4 nurses and 7 medical doctors that take shifts every weekday between 8 a.m. and 8 p.m. 2 nurses and 1 doctor each shift. As you would reckon, the variety of our visits and tasks are as heterogeneous as the population of the elderlies. Some are quite simple and can be solved in 1 or few days, while others demand longer process and follow-up. And it's so precious to be able to offer that kind of support to the home care service. Like in the case of a man I hear called Einar. Einar is a 99-year-old man living at home with 2 of his grown-up children. Einar enjoys the company of his family, and he loves to read books and solve word puzzles. He has made it clear he never wants to go back into the hospital, and he wants to live at home. He's had multiple incidents of pneumonia and wound infections, and he has a vulnerable balance of heart failure and dehydration. His body weakness has resulted in 24/7 demand of care and support from his son and daughter, who are 45 and 57 years old. And they live with him in their apartment. Before Selma came into the picture, there was no other option than to call for an ambulance and bring him to the emergency department for medical treatment when his condition turned bad. But the last 18 months, Einar has been able to stay at home and get the assessment and treatment needed there. The formal home service has been increased during morning and lunchtime to take care of his medical treatment, nutrition assistance, and hygiene. And we were also able to get a regular respite at home from the social service 5 times a week, and in means of increasing the security of his children to attend their own program and work, as you would reckon. The focus has been on repeated integrated conversations with Einar, his family, and the formal home care providers, along with his family physician at the primary healthcare center, to keep everyone updated and have a saying on the situation and its options about Einar's wishes, along with the family's needs and worries. With the support of Selma, we like to see home care becoming the center of support to frail elderlies at home, and in active collaboration with every aspect of the healthcare service chain. By strengthening the contribution of home care nurses and empowering their professionality with backup and support from specialized home care team, we can both improve the service provided to senior citizens and strengthen the collaboration between service sectors, breaking down those much mentioned silos in our healthcare. And if that can lighten the burden on the emergency department, that's good also. But not all our patients are nearly 100 years old and have all the family support they need. This, for instance, is not the case with a woman I name here, Sigrun. Sigrun is 71-year-old, lives alone in a small overloaded apartment on the 3rd floor, which she has not stepped out of for more than 4 times in the last 3 years. She has no support from or connection to her family, and she is one of our many cases of individuals living in what I would say unacceptable conditions. Sigrun has physical and mental issues that do not really fit the common pathway of our formal care. Today, Sigrun is dealing with a major depression. She's afraid of stepping out of her home, and mentally, she is not able to accept the help she needs. She has a severe swelling edema, an infected ulcers. She refuses any support she has been offered at home, and despite many attempts to bring her to hospital treatment, she still sits at home in her lazy boy. 8 weeks ago, one home care nurse was allowed to put bandages on her leaking ulcers. But since then, no one had been allowed to attend the wounds or change bandages. So you just can imagine the situation of her infected feet. The role of Selma was here to bring into the conversation the specialist of the wound care from the hospital, have the specialist to come with us to her home, and together we managed to win Sigrun's trust to allow us to clean up the wounds and set up a plan for further treatment. We then called together for a meeting all those professionals who have a role in her support, including her psychiatric team. But in the case of Sigrun, we are aware that there is no simple solution. We will continue a delicate dance back and forth in her service, but we believe that bringing into awareness these multiple aspects of her health and social care needs and drafting up a shared plan, we feel that the professionals could gain back their energy to do their best in Sigrun's daily care, that they will feel not so alone anymore in their project, and that could make a difference. These stories that I've told you are in my mind the essence of holistic nursing and are of great importance in showing the meaning and outcome of this enhanced home care for frail elderlies. But the government understands numbers, and numbers sell. That is why we emphasize also on counting our cases and clear their outcome. As I told you, Iceland is a small nation, but for the first 18 months, Selma has been of support in 400 cases of home care in Reykjavik, which counts for about 10% of all individuals that receive home care in Reykjavik city. So it's the critical 10%. And that is in harmony with the need of specialized home service in other countries. We see it in Canada and in Sweden, which we have been particularly looking into as our role models in this kind of care. We've also been in contact with the ambulatory multidisciplinary unit here in Oxford to see how things are done. But every place has its different needs and ways of approach, but it's good to be aware of how things are done in different places. As you can see here in this table, 75% of every case that Selma attended was closed at home. But as we could predict, we did need hospital admission for some of our frailest patients in acute situation. It's important for us to see that of those that we did have to send to the emergency department, over 80% were admitted to the hospital ward for a special treatment that was not possible to provide at home. So that is good for us to know that we are not sending people like a yo-yo back and forth from their home and emergency department. They go there in for a reason. To put this in context with the fundamental of care model, and to explain why I thought it was important for Selma to have a voice here at this conference, I would like to emphasize how this model motivates us to keep the conversation ongoing at every level and also between levels of systems. It inspires us to shift the focus toward the multi-layered needs and wishes of frail elderlies, and to expand our spectrum to psychosocial, physical, and relational holistic approaches, both as professionals and human beings. I have used this model as a guidance in my support for home care nurses, and also when arguing on a political and systemic level for the importance of enhanced home care service. The next step will be to implement a use of this approach within the home care staff in Iceland. So I thank you all for being here. for giving your time and focus to fundamental care, and for being such inspirational model to me and others worldwide to do better in the care of our people. Thank you.